discovering proper medication. After unsuccessful trials, his healthcare providers found a regimen that allowed him to live his life, for the most part, unaffected by the virus. It is with great joy that Mr. Walker shares that he is now cancer-free, and with Cabenuva injections. So it's with great joy that Mr. Walker shares that he is cancer-free, and with Cabenuva injections, living a healthy life. Next, Mr. Walker's right, Jacina Sims. Jacina Sims, MPH, has been the program manager for Sinai Infectious Disease Center since February 2020. She previously worked under the same program as a Ryan White medical case manager after receiving her Master's of Public Health, Community Health from DePaul University. Her early interest in sex education and women's health turned into a love for HIV prevention and care, reproductive and mental health. Jacina is a part of several committees and task forces that are working to improve the lives of others that are part of underserved and marginalized groups, such as the Women's Connection. She works to improve access to care for cisgender and transgender women of color within her organization.
Hi, I'm Sydney. I'll be introducing our final two panelists today. Third, we have Dr. Lauren Beach. Dr. Lauren Beach, JD PhD, is an assistant professor within the Feinberg School of Medicine at Northwestern University. They are also the director of the Advocate SGM Health Program within Northwestern's Institute for Sexual and Gender Minority Health and Wellbeing. Scientifically, Dr. Beach investigates the epidemiology of chronic physical health conditions over the life course among diverse SGM populations and people with HIV. They also study how multi-level health and identity-related stigmas and resilience-promoting factors affect chronic condition management and health outcomes of minoritized populations. Finally, they study the measurement of sex, sexual orientation, and gender identity. Dr. Beach is active in community-led, evidence-informed advocacy efforts to promote LGBTQIA+ health equity. In particular, they are nationally active in bisexual health policy, leadership circles, and have spoken at the White House, CDC, and NIH to present recommendations for improving bisexual health. You can follow them on Twitter, now X, @Lauren. And last but certainly not least, we have Dr. Jakadisha Dakis. Dr. Jakadisha Dakis, PhD, MSSW, is a research assistant professor and the associate director of the Institute for Sexual and Gender Minority Health and Wellbeing, or ISGMH. He received his Master's of Social Work with a concentration in Advanced Generalist Practice and Programming from the Columbia University School of Social Work, and his doctorate from the Graduate Center, City University of New York in Social Welfare. Before joining the faculty at ISGMH, he completed an NIH-funded postdoctoral research fellowship at the HIV Center for Clinical and Behavioral Studies at Columbia University and the New York State Psychiatric Institute in the Division of Gender, Sexuality, and Health. Dr. Dakis's research qualitatively seeks to identify and understand the psychological, social, and spiritual strengths and resiliencies that contribute to maintained HIV seronegativity in Black sexual minority men. He is also the director of the NIH-funded Summer Intensive Program in Intersectional BIPOC SGM-focused HIV science. The program serves as a pathway to support the next generation of BIPOC SGM scholars who have an interest in health disparities and health equity to conduct high-priority HIV research with BIPOC SGM populations and communities. Thank you all very much. These are our panelists today. Now we'll hear a little bit about each of their journeys and areas of research. Thank you.
I don't think your names are supposed to be in order. You guys want to speak on? Whoever, just in my first one. Everyone's sorry, really quick note, our mics are like louder in the back, unfortunately. So if you could enunciate specifically, so our online folks could hear you. Great. Thank you.
I would like to say good afternoon to everyone. I started years ago when I first discovered that I had HIV I went to my doctor and, he told me I had it, but the HIV, I really didn't have so much of a problem with that. Cause they were trying to find various regimens for me to take, so I was taking them, and I would tell him that, they wasn't working, or I was sick from it. But I didn't learn, and then I had to go back because I started falling out, and I thought it was due to the HIV. And I come to find out that it was cancer, non-Hodgkin lymphoma, and that was worse than the HIV because I was all right with the HIV, but I wasn't all right with the cancer. Cancer took away my memory. It took away everything for me because it started going to my eyes, to my brain, and I was taking shots every month, spinal taps every month, so they could keep it from going to my brain. I just I recently learned, not recently, but I had to go start back over learning how to read, because I couldn't read. I had to start back learning how to write. I couldn't tell time. I couldn't dial a phone. That was the second time it came back. It went away for 6 months during the time I had it, but it came right back in 6 months. And then came back worse because it took away my ability to walk and everything. And they wanted to send me to a nursing home, and I told them I wasn't going there. I wanted to come home. So they sent the bed. They sent everything I needed for me for a bed, and they had somebody to come and take care of me. But and I asked them to send me a wheelchair because I couldn't walk, and I didn't like that. So I asked them to send me a walker, and I didn't like it. So I asked him to send me a cane. And as I looked, I was living on the third floor of my apartment, and I was looking down on all the way down, because I couldn't walk down, but I could go and look down. And I said, one day, I'm gonna walk up them steps. And I had a personal assistant put me out in front of the class to take me to therapy. And he parked the car, he put me out in front of my door and told me he'd wait for me there. And I went on in and I walked up the steps. I said, oh, now I got it. And what I'm saying is, during this time, you can't let cancer fight you. You have to fight cancer. If you have to fight HIV, you just can't live with it and say this is it. But I thought one time I wanted to, but the birth of my daughter made me decide that I got to live with my daughter. And I started doing things for my daughter, and I got better. But it's a thing that it takes a lot of encouragement. It takes a lot of your fight and your ability to cope. If it's not for you, you constantly, you will not get over it, or you may pass away. And see, I tell everybody, I'm gonna live to get 100, regardless of what happened to me. I'm gonna be able to get 100. And so far, I'm 70 years old, and I'm still, I just got over cancer treatment about a month ago. I was taking it 21 hours a day. Chemo was 5 days. And they didn't think I was gonna be able to go through it, but I went through it, and they were surprised. They said, I didn't think you were gonna make it. I said, oh yeah, I can do anything, and you can do anything, but you got to make sure, you got to have faith and hope. And see, I learned that from being a minister, how to have faith. You know, we know that they say faith without hope is dead, and it is dead. If you don't have the faith, you won't make it. You just can't make it, because it takes two. It takes somebody to encourage you. That's why I tell people, if they go to the hospital, have someone that come and to see you every day, just encourage you. Don't bring you down because you're already down. Encourage you. And then you have to encourage yourself. If they don't encourage you, encourage yourself. I always go through, I can do this. I can do that. And I think about the thing that I think about these things, and I look around and I say, oh, I'm gonna be able to do this. And that's how I make it each and every day of my life. And I'm hoping that, and I just want to say, don't ever give up on whatever they say you have. Don't ever give up, because you can make it, because I am one to show that you can make it.
guess I'm next. I'm Justina Sims, she, her, hers. I'm the program manager over at Sinai Infectious Disease Center, and I basically supervise or manage our navigation team as well as the case management team, and then do a whole bunch of different miscellaneous tasks that help all the different programs that we have to basically flourish as best we can. One thing to highlight, I'm not a researcher, but specifically the programs that I currently want to highlight are our free in-home HIV test kits. So people can order those, do the OraClick test at home. It's a mouth swab. And we can do drop-offs, we can do shipping as well as pickups. So if anyone is interested in that, please let me know. We have a navigator that can work through the test with you if needed, as well as do pre and post test counseling. Another program that we work with is the Cease HIV program, which is also in part with Northwestern. So through that, we have our low barrier care clinic. That's something that's newer for us, where we have a walk-in clinic twice a month. And it's really geared towards getting patients who are not virally suppressed and often not in care. Some people are kind of in and out of care and just have not been able to reach viral suppression. So our focus on them is just figuring out, like, tailoring to their needs specifically. Some patients need more of an after hours clinic, others need weekends. Sometimes incentives are something that can really help patients either just meet their needs or just be more of a encouragement to get their numbers down. So that's a major focus of ours right now. It's been pretty successful in reaching quite a few of our patients. Some people just fall out of care because, one, they don't often think that someone cares. They just need someone to reach out and kind of remind them that we're here for them and that we can help them as best we can to remove any barriers to their care. So I'm really proud and happy of the programs that we have over at Sinai. And then I'm open to questions about that.
I actually have a question. It's probably both of you all can actually answer it, but it's more targeted, I think, to Minister Walker. Walker, right?
Right.
With the dual diagnosis, how was it navigating through the healthcare system? Because I already know that that can be difficult. So how is it with the dual diagnosis, navigating through the healthcare system? How was that experience for you?
No, I had lawyers to help me. And they were the ones that helped me through this navigation of healthcare. And he was telling me about it, so I made that's the way I made that change in the healthcare. And I had a very good doctor.
I had one for Mr. Walker. So with that dual diagnosis, I noticed you said earlier that you kind of didn't really mind the HIV, but the cancer is what you minded more. Why is that? Why was that your feeling?
Well, my HIV, it wasn't, I never was sick. And I never had to go any place but the doctor's office, his office. My HIV, it never came to full-blown AIDS. I've seen people that had full-blown AIDS, but it never happened to me. And so that's why I said that the cancer was harder on me than HIV, because the cancer came with vengeance. They just took away everything. And my life to live, I thought it was over. And living, and I'm gonna tell you, living and raising a child on your own, I was the mother and the father to my daughter. So it was harder for me to raise a child and live with cancer and HIV.
Thank you.
All right, good afternoon, everyone. I'm Lauren and I use they, them pronouns, and I am a faculty member at Northwestern. And my research really focuses in on chronic conditions and aging. So I direct the research in aging, health, chronic conditions and health equity and the Department of Medical Social Sciences, and then a program that really focuses on clinical and translational research in the Institute for Sexual and Gender Health. Oh my gosh, I can't even say it. It's Jim. Oh my gosh, funny. Have a lot going on today, you know. But I was really excited to be here today because it's World AIDS Day, which I don't know if that's really been said out loud yet. And World AIDS Day, I was really excited to join this panel because of actually having you, Minister Walker, be on the panel. Because I think that World AIDS Day should be a time to center people with HIV and to hear from the stories that they have, hear from the community and lift that up. And I agreed to join the panel because of your voice being on the panel. And so I just want to say shout out to the organizers of this event for making it happen and show up in this way. And my work, I do what I do because of love for the community. And I felt that it's really important, even from the start. I didn't know I would wind up here. I started off in like a basic science, bench science training. And I'm bisexual and also asexual, non-binary, a few different identities within the community. And I wanted to think about a way to show up to do scientific work that could be connected to advocacy to make a difference for health equity. And so I started off with back in 2003 at Michigan State, when I was an undergraduate, like investigating innate immune responses to HIV. At the time, we didn't even have the full human genome mapped out very well, but was doing some genetic work in that. And then my PhD, when I thought about how can I connect to the community, I joined a lab that did work trying to understand if existing drugs that were approved by the FDA could be used off label as part of like salvage therapies for people with HIV who've been having drug resistance because they'd had the like long-term survivors basically. And so I think after a while, and I went through a program, I got my law degree at the same time and specialized in health law and bioethics. And I eventually realized that public health was a thing that's what I should be doing if I wanted to be closer, you know, more in the research pipeline where you can make an impact for human health in the community. And so now my work, as was talked about, really has there's a number of projects that I've had that are funded to look at. Most recently, it was to look at cancer care cascades among people with HIV. And to do that, looking at electronic medical records data from both Northwestern's health system and the University of Chicago's health system. And it wasn't, you know, so what are care cascades? I think when we're thinking about World AIDS Day, we should definitely have a plug, and you already did this with what programming is with in-home testing kits for HIV at Sinai. But you know, care cascades for HIV start with getting tested. Then after that, if people find out that they are living with the virus, then the next part of the cascade is making sure that they get connected to care in a timely fashion, ideally the same day as testing positive. And then following that, it's about making sure people get treatment that works for them and helps them become undetectable and have minimal side effects from the medications. And then from there, it's staying in care, making sure they don't fall out of care. And then ultimately, we're looking at making sure that the virus is undetectable and maintaining that. For cancer, the care cascade is not as well defined as it has been for HIV, but I think it's similar. You know, once you find out, like you get screened for cancer, then you find out that you might have cancer, then it's making sure you're connected to treatment, that you get the treatment and that the cancer goes into remission. That would be that. And so this grant looks at among people with HIV, what are their cancer care cascades and also what are their HIV care cascades. And then on top of that, it does that according to social determinants of health. And so social determinants of health include things like your education, how much income that you would have, if you might be having a mental health diagnosis or a substance use diagnosis or other sorts of components. Are you safe at home? Do you have access to, can you pay your utilities? Do you have food that you need to eat to be healthy? Is that easy for you to access? Those types of things. And so it is looking at care cascades by those social determinants, and also there's an intersectional frame to it where we think about intersectionality as being a Black feminist frame, critical frame that centers the importance of thinking about how systems of power also would be affecting health in that application. So how does racism intersect with homophobia, biphobia, transphobia? How does that intersect with sexism or other sorts of isms to affect health? And so I was thinking about like, how do we, when we look at data, I think it's important to center that there are people and communities in the data that if you don't focus on that, it's invisible. But that grant will seek to like look at intersections of multiply constituted identities and social determinants of health to look at how people are navigating care for HIV and cancer together in two very different health systems. UChicago is a Ryan White health system, and Northwestern is not for HIV care. And so that automatically has differences that arise with that. And I really want to say a couple of things before I close, which is one of the reasons I was excited to get more into this work. Half of all people with HIV are 50 and older in this country right now. And that's because you can live with HIV, right? And I think that's important to say, like with the treatment that's out there today, you can live with HIV and have a lifespan that's almost identical as if you didn't have the virus. And so that also means though, that as people get older, you know, aging is the #1 risk factor for having chronic conditions, right? Including cancer. And so what I really want to center too is that with people with HIV, studies have increasingly found that if you access cancer treatment, your likelihood of getting to cancer remission is the same as if you did not have HIV. And the difference in why there are disparities is social determinants of health. And so that I think is, and I feel like the stories we heard today, it really shows that like you can get through cancer even 3 times and still be making it. And that actually looks the same as if you didn't have the virus, if you have the right support systems. And the right resources in place. And I just want to put that message out there because for us to achieve that, you know, to make sure that equity is in place and that promise that we know is possible comes to life, then we have to do more to address the social determinants of health. And that's why this project is seeking to, like, one way to start to do that is to just look at what we are getting from health systems. And part of why it has to be health systems too, is it's like, that's where the data is going to be about HIV and cancer, you know? So you got to go to the source of the data. But I think you can't do that without moving forward for interventions with community. And that's really where I think that the work would go first. With that, knowing that you can get to the same outcomes if you invest the resources and navigation to address those determinants. So that's what I'll say.
Good afternoon, everyone. Welcome. Hi. First of all, I want to thank my co-panelists and also the organizers, and thank you folks for joining us here today on this Friday, and folks online, thank you for joining us too. My name is Jagadisha, and as I was introduced, I use he, him pronouns. I am similar to Lauren, research faculty here at ISJA, and I'm also the associate director, so I'm part of the thought leadership at the Institute. And I come to you, I like to always, like when I give presentations, like share with people how I center myself in the work. So I come to you as a Black gay man, as a social worker, a very proud social worker. And when I talk about my work, you'll see how that plays out. And also as someone who really is invested in giving back in many ways. And you know, my career trajectory has really gone from direct service as a practitioner to a clinician, to managing programs and organizations, to being here in academia. And I say that because I think it's really important to understand, as when I talk about my research and my work, that, you know, I offer a perspective that I like to think is very well-rounded, you know, based on what my engagement with people have been at various levels, at the individual level, the community level, also at the structural level too. And I had a little, dipped my toe a little bit in government that I'll talk about a little bit too. But, you know, how that really comes into play and how I bring myself into the work. Because like many people, I'm sure, as I've seen heads nod here, the personal is professional and the professional is personal. And so, you know, I'm a person who really, when I give, I like to give a lot and like to be really committed to, as I have my profession and my career in HIV. So having said all that, can you tell I'm a qualitative researcher? Having said all that, My research and my direct service and my practice have really centered in HIV. And I didn't intend to become someone invested in the HIV field. Like many early career social workers in the mid-90s, I wanted to do child welfare work. That was where my heart was. I am a proud Head Start graduate, and my first professional job out of college was actually Head Start. To make a long story short, I started volunteering with an early aid service organization in Oakland at the time. I was going to Berkeley as a student, as an undergrad. That is pretty much one of the largest ASOs in Northern California at this point. And I started to really volunteer because in my community where I was living, I started to really just see like the impact of HIV. I was living in West Oakland, and people who may know the Bay Area at the time in the late 80s and early 90s, West Oakland really was an under-resourced community and environment. And my life had been touched by HIV early on, people in my life who were like family to me, but also friends. And I started to notice that started really waking up and started to see what was happening. And I really wanted to figure out a way that I wanted to be able to give back. As an undergrad, I actually wanted to be a marine biologist, believe it or not. I wanted to be a black Jacques Cousteau, swimming with the dolphins and whales and the sharks. But I had this calling, right, where I wanted to be able to give back. And social work really resonated with me because of my experience, my childhood with social workers. That was very positive. And also being a social worker would allow me to do things in a very versatile way. So I began my HIV career when I started my graduate program, and I primarily focus on youth and young adults, purely focusing on young adults of color doing HIV prevention program in New York City. And so it was really a wonderful opportunity to engage with community, to engage with stakeholders, to engage with policymakers, right? And to meet other people who look like me in the field who were doing this. Because at the time, if you had asked me when I started my graduate program or finished it at the end of the 90s, if I was going to get a PhD, I would have said, what? Are you kidding? No, that's not for me. Until I saw myself represented and people who were doing things that I wanted to do. So it was very inspiring. And I think on World AIDS Day, I always think of it as an annual call to action. It's something where it's like, wake up, Jagadish, wake up. This is your time to be activated. If you're going to start, if you're going to be activate yourself at any other point in time, do this, because you have a way to help contribute to the advancement and the eradication of HIV, like other people who are here in this room and other people who are interested. So let's talk about my research, right? So with all that, as I was working in various capacities in New York City, in nonprofit settings and also in government, I was at the New York City Department of Health and Mental Hygiene for a number of years. As I was thinking about embarking on research, I really wanted to focus on, really kind of people who were like me. One of my mentors, who is a prominent HIV researcher, Dr. Daryl Wheeler, we were at a conference in Atlanta in the mid-noughts. And that's when CDC released data about Black sexual minority men and such high HIV rates among them. They had estimated that 46% of Black sexual minority men or Black MSM were living with HIV at the time. And I said, well, what about the balance of that? Right? It's like, what about the balance of that? When we talk about prevention, we talk about primary prevention. What data or research is there? And my mentor said to me, he's like, well, maybe one day, Jagadish, you'll study that. So fast forward about 9 years later, I began and embarked on my research career. And it really meant a lot for me as a social worker, because as social workers, we assess for strengths and assets. And I knew that, that I could explore scientifically that it wasn't just luck that these men were able to remain HIV negative. And you have to think about this. This was before the availability and wide-scale distribution of PrEP. So I was really looking at, it was really behavioral science, behavioral and social science I was looking at. And, so I wanted to, hear the stories of these men and really understand and be able to share with the world, right? That, Black men in general are very pathologized in our society in the US, right? And I wanted to offer some counter narratives to the pathological understandings or even assumptions about Black sexual minority men. So through my research, I take a strengths and resilience-based approach. And fundamentally, what I've been able to find is that these men who are able to remain HIV negative, given such high burden and impact on Black sexual minority men here, are able to do so because of the skills, the encouragement, and things they learned to survive as young Black boys and men in our society, which is inherently anti-Black. Many of the men in my study would say, hey, HIV is just another thing I have to deal with as a Black man. I know it's it's another thing, but I can actually deal with that because I have support. And what I found were some very fundamental things. One is that they had social support from not just friends, but also from family and communities. So I was able to offer counter narratives about Black communities and families being inherently homophobic. Right? They were people who were in their lives who really supported them and embraced them. And then other things were that, you know, they had a strong sense of like spirituality and how that guided them in their purpose, right? Another thing I found in terms of an asset and strengths is like their ability to exercise their agency in various sexual situations and negotiate that. And, you know, understanding not everyone is engaging in safer sex practices during every encounter. But these men were using risk and harm reduction approaches, which were mitigating their risks, right? And so, you know, really being able to offer that to the world and offer that back to the men and say, hey, you know, you're not alone. You're not the only one. You know, we have this, you know, this body of research, and it's really nice now that there's a strong strengths-based and resiliency-based approach to HIV research, specifically with this population now. And so, you know, I'm here and, you know, with my esteemed colleagues to be able to offer my perspective sort of largely around HIV, you know, and specifically around Black sexual. Oh, wait, I'm sorry. One more thing I want to say. Sorry. Yes, my last thing. Thank you. You reminded me. Thank you for the psychic message. Yes. Is that, you know, one of the ways I give back to is at the end of the introduction. Thank you for that. They mentioned a program that I run. It's an annual program. It's a summer intensive program. And it's really to advance and encourage through sort of a pathway mechanism, BIPOC or Black, Indigenous people and other people of color, sexual and gender minority, you know, early career researchers who are interested in HIV science, specifically with the populations and communities that come. So think about like crafting that in this environment, right? This, you know, top 10 university with an opportunity to really bring in folks whose identities represent some of the most marginalized and impacted by HIV. For them to be able to have the skills and training and knowledge and mentorship and networking to be able to give back and strengthen their research chops and engage their communities.
Thank you to our panelists for helping us center HIV and AIDS today and providing such a unique perspective and experience on the topic. In our next phase, we're going to ask a series of questions that you, the audience, have sent out to us. We invite our panelists to share their perspective. First question. In what ways are you or your project actively trying to destigmatize or reduce the negative propaganda around HIV and AIDS? Any of our panelists, feel free to answer.
I know over with Sinai, we definitely try to, like, through our social media as well through internal email blasts to our system to just educate folks as best we can. Oftentimes there's a lot of miseducational or lack of education around what HIV is, who it impacts, and that definitely adds to the stigma when people think there's only one population that can acquire HIV when that's not the truth at all. I see so many different walks of life within our clinic, and there's so much stigma around it for people being labeled as promiscuous or drug users. It's only a gay disease when that is far from the case, when we know that we also have a maternal and child health clinic as well. So it's definitely reduced now with babies being born with HIV. But it definitely needs to be a focus. Just the education overall is super important to removing stigma. Through our social media, we include what HIV is, different measures of prevention, and treatment, whether that's injectables or it's just a safer sex toolkit. Some people do not realize how much lubricant can be a safer sex practice and HIV prevention, as well as condoms.
Maybe a good follow-up to that is there's oftentimes a lot of misconceptions around HIV and AIDS. you all share some of those misconceptions with us and actually the research back data that is different from those things?
One of the things that I have seen a lot of is people think that the government made HIV. But that's, I mean, seriously, this comes like that HIV is actually like something that was. And it brought in especially harm like Black people, other people of color, like, you know, minoritized people in various ways. But one thing that I want to say, obviously this room knows that HIV is not made by the government. It's out there, and actually there's a lot of other viruses like it. It's what's called a retrovirus, and that there are a lot of retroviruses. HIV is not even the only retrovirus that infects humans. There's another one called HTLV, for example, that actually can cause cancer. Leukemia, lymphoma that is out there, and there are other types of viruses like HIV that can infect other, you know, and other animals, you know, basically. And so there's like a long history of the evolution of viruses that are out there. It's not something that was made up to harm communities. And there's also like treatments. Obviously, sometimes people think that there's a cure for HIV that's out there that's being withheld. There are a few people that have been cured from HIV, and strangely enough, those people have all had cancer. And the reason for that is the only cure that's been found so far for just like 3 or 4 people in the entire world is to basically, you need to irradiate somebody more or less, and it kills off their bone marrow cells, and then the person is then given a treatment where they get new bone marrow producing cells. I'm just trying to say this like lay language. And they then have basically immune system that lacks a co-receptor for the virus, and so the virus is no longer able to replicate in their body, so they're cured of it. But it's a very dangerous thing to do, because going through that type of a treatment has a lot of risks. And there's not actually a cure right now that's out there that is for HIV, other than that really risky set of treatments that only people who would already have certain kinds of cancer would undergo. And even then, there's a lot of complications that go along with it. But yeah, HIV is real, out there in its natural world, and there's no secret cure. Those are 2 things I get a lot of questions. I've had a lot of questions about. I've done other community events. I don't know if that answers anyone's questions, because I don't know who asked that question, but those are 2 important things maybe.
How common is it for someone to have a dual diagnosis like HIV?
It's a really important question. I was trying to look at the exact numbers. And what I can say is that there are certain cancers like non-Hodgkin's lymphoma, as well as cervical cancer. And gosh, there's one more that's slipping my mind. Oh, Kaposi sarcoma, that are more common among people who have HIV than people who don't have it. And those are called HIV associated cancers. And so basically very few people who, for especially Kaposi sarcoma, very few people who get that, they don't have HIV, although there's some other populations that do get it. And then there's other cancers that are non-HIV associated, and that's like most everything else, meaning like in general, we wouldn't think that HIV itself would confer an additional risk to getting those cancers. And then like in terms of the biology of it, but then maybe for some reasons like social determinants, other cancers are higher. Like thinking about HPV or other like cancers that are associated like with viruses tend to be higher among people with HIV. And then cancers like lung cancer are a little bit higher among people with HIV because of there's a thought of like higher smoking and other behaviors and environmental factors. I don't have an exact number of the number of people who have HIV who also have cancer, but I can say that for a lot of the cancers, there's not like an extra risk that's just tied to the virus, but then I just outlined the ones that the risk is a little bit higher. And so what that would mean is that there's more and more clinical guidelines, thankfully, that are emerging, tailored to people with HIV for like doctors, nurses, like care teams to look at, because people are living longer when they have HIV, so they're more likely to get cancer, because the longer you live, the more likely you are to get pretty much any condition. But just thinking about it that way, but cancer included. And so what I think is important is that there's getting to be more tailored guidelines that also address screening for cancers. I think it's important to have an anal pap to screen for anal cancers. And if somebody in particular is having anal sex, that's going to be important to screen. There's ways to screen for lung cancer now, like CT scans and other things that you can request for cancer screenings. And I think those are gonna be, I just wanted to mention that not just screening because of this event, it's not just screening for HIV, it's like the screening for cancers that are important, especially if you are someone who has HIV. Get cervical cancer screenings, get lung cancer screenings, get screenings that would be tied to anal cancers or other HPV associated cancers. Those are important things to center for your health, like if you are someone, whether or not you have HIV or not, but especially if we're centering, today's World AIDS Day, we're centering people with HIV, I want to say that. Is that helpful? I know I didn't.
No, yes, it is. I'm Monique. I'm the Community Outreach and Engagement Coordinator for the Cancer Center.
Awesome.
So while you guys are talking, I'm thinking like, okay, I need an event where I need people to talk about dual diagnosis.
Yeah.
And I was asking that question for that reason, and you brought up cervical cancer in January, cervical cancer awareness month. So if you guys just happen to get an email, just saying. Thank you.
You know, I think I can quickly just actually answer both those questions you just asked. So one of the ways that I have attempted to destigmatize HIV is I provide a lot of training capacity building to organizations that provide services to various populations. So, you know, really taking you know, my expertise and knowledge and really giving back in that way and helping people understand and actually address some of the barriers. Because we understand that, like, you know, the client-patient experience begins the moment they step in the door, right? And if there's, you know, the person who's engaging them primarily, or they meet the first person they meet and they walk in the door, you know, if they have an experience of any sort of like discrimination or bias, that really can shut them down and turn them off and not make them close down for services, right? But also we understand that provider bias is real, right? And, you know, providing, you know, continued training and, you know, opportunities to increase knowledge and applying skills to providers so that way they can, you know, reduce the bias, even if it's unconscious bias, right? When they engage their patients or clients. The other thing is through my research is, as I alluded to when I gave my introduction, is, you know, I talk about depathologizing specifically the population that I work with, but largely just helping to destigmatize, like, you know, people who are living with HIV because, you know, there are people who are living like, you know, who have very like wonderful existences, right? You're living very healthy. There are people who are not living with HIV, right? And that's not their identities that put them at risk, but really it's like, you know, it's what they engage in, like those behaviors, you know, and it's really unfortunate that, you know, the belief still to this day is that because of people with very specific identities, right? So they're believed to be at higher risk. So helping to debunk that.
So we had another question from our audience that is in a bit of a different direction, but I believe all of our panelists today have talked about the power, importance, and influence of community. So one of the questions we got was, can any of you speak to the resources available for patient primary caregivers and sort of the experiences of caregiving in terms of mental health and education on primary caregivers? Yeah, of course. So what are the resources available for patient primary caregivers, and what are some of maybe the roadblocks or struggles in terms of mental health or like education that we see in communities who support impacted patients?
I can elaborate on that. So I know, for example, our patient speaker actually is here with his, I want to say, primary caregiver.
Yeah, my partner primary.
Yeah, so we understand, well, the impact of these viruses and cancer on the patient themselves, but sometimes the caregivers overlook in a sense that taking some time, for example, my grandmother passed of cancer, so I understand that, you know, putting your life on pause to take care of a partner, a family, a friend, a loved one. So what, speak on that, also if anyone is aware of any resources that are available to, I don't want to say support groups, but whatever education is what education is there for those who are in that position of being in primary healthcare and what their life now looks like because they are in charge of this person. Yeah.
Well, I was blessed to, be someone that had the experience. My early experience of it, they didn't have very much knowledge of HIV or cancer. So you either had to tell them or don't say anything at all. And during my time of it, it wasn't talked about. Not HIV nor cancer was talked about, but I learned to tell it and let them know. And that's the only, that's a good education for, primary, caregiver to know if you can talk about it. See, in my time, you didn't talk about it. You carry it to yourself. You just didn't say it. But, James, he came in knowing, when he saw me, he knew it. He looked at me and he told me, and I didn't say anything to him. I let him do all the talking. But you have to tell and talk about it, to educate from the PAs that you have. And that's the way I think that works out. I learned a lot by just knowledge and being taken by taking. Even the people that was seeing, they weren't saying very much about HIV and AIDS. They just said you had it and that was it.
I'm not really sure so much about resources in particular, but it's definitely important as a caregiver to speak with who you're caring for, like what questions do they have? What do they not know about their condition? And then being able to advocate and speak up for them wherever you can. Um, Sometimes patients, they don't always remember exactly what it is that they wanted to ask a provider. And then you can just basically advocate for them, be able to raise those questions and also look at it from a different lens as you're not the person being treated. It's oftentimes as a caregiver easier for you to digest the information that's being given to you and then be able to explain it to your patient or who you're caring for in a way that they can understand and then just be a good support system for them overall. Sometimes you do have to go through your own research. I definitely recommend finding out what organizations like the American Cancer Society, reaching out to them and basically explaining what the situation is and see what resources they can point you to. Oftentimes the leading organizations can be the best resources, education and support.
Yeah, I think that there's a need to develop caretaker resources more and interventions more that support both people who are living with dual diagnosis and also their support systems around them. And there are not that many interventions that are out there, and those that are, I don't think I know any tailored to people with HIV and cancer at the same time. And there also aren't that many that would be tailored to like aging in terms of like people with HIV or LGBTQI plus people and aging. Like there's just not that many caretaker interventions that have been developed. They're tailored into the populations either. And there's a need for it. And so I think like as some of the projects that are being done that look at some of the data systems, then it's going to be really important to be talking and like doing the qualitative work in the community too, to talk about like, all right, what is needed to improve support and make things more sustainable? And how do you tailor that to people who would benefit the most from it? And I think that's a really great question to have asked about caregivers.
Well, that's a great segue. So we talked about, the patient, the primary caregiver, and we have a lot of prevention workers here in the audience that ask the question, how do we as prevention workers raise awareness and the lack of education and funding resources in Black and brown disenfranchised communities? They'd like to know, what do we do to get more funding for these communities?
write a budget. You know, sort of one thing I talked about, I have a student who's doing an Apex on this exact question, like the question, the project is for gynecological cancers, there's not funding out there for Black and brown people with gynecological cancers. There's not funding for LGBT people with gynecological cancers. And there's a commission that the Illinois legislature created about gynecological cancers. And so there's like 20 people who's supposed to be on the commission. And then the question is like, well, how do we get a budget? And the answer is like, the Illinois Department of Public Health was like, come to us and tell us what budget you want. And then you have to go to the legislature and they'll approve the allocation from IDPH to do it. So you literally, like, part of it is like, and that there's like this group there in that case that's specialized in that context, but that's because of community action to pass that. You know, so like I think that's just one way in terms of getting money from the state, because they owe it to people, like the public health agencies need to be doing better, and I think you demand it. And I know there's at least one project that's in the gynecological space. It's not for cancer, it's not tied to HIV, but I feel like you come in, you say, I want this number, here's the IDPH budget, you need to put this money into this now. And like demand it and work with the community to help do it. I think and it's not just on the community to do it, it should be that they're already doing it, but they're not already doing it. So you've got to make noise and demand it and say, you know, ask for 10 times what you think you need, so you get what you need. You know, I mean, it's more complicated than that. I'm not trying to put the onus just on the community, but I think that's one model I'm seeing right now that is going on with that gynecological cancer space, to get that budget into Black and brown communities for those cancers.
But they seem like they taking the things that they get away from you.
Yep.
They call, oh, you get this, you got this, we're gonna take this away. And I know that through experience, because it's been happening to me. And the things that I used to could do, I can't do anymore, because everything, my resources are ran out from what they were doing. And that's something that I really would like to know how or who do we talk to about this? Because they're taking it away instead of giving to the community or to
Okay, fine.
All right, I'd like to ask another question. What major challenges do you think people living with HIV will be encountering far in the future, like within the next 10 years?
Well, I'm hoping that in the next 10 years, it'll be better than it is these 10 years, because I think people live longer, and I think that they could do better with their lives and their life. Because a lot of things you lose during these times, you know, because you don't say anything, you are very cautious of what you do and say and who you're around, because you're scared to tell this person because you don't know their reaction with it, you know. And some you can talk to, but everybody you can't talk to, so your life is almost at limbo because you don't have no resources out there to help you.
I definitely agree. I hope that in the next 10 years that it's easier for people living with HIV and not getting harder. The more that we can advocate for people living with HIV, voting and really getting our representatives educated on these different causes and being able to get them to push funding towards the resources that people need is super important. I just hope it improves and that stigma is lessened and less barriers to care. I often think about how different our health outcomes could be if we had a better healthcare system overall for everyone, more health equity.
Another question asked by the audience is, how does one communicate about HIV and AIDS education considering different cultures? Kind of touched on it a little bit, but if we could dive a little bit deeper in terms of how does one truly communicate about HIV and AIDS education, considering different cultures? As an example, an audience member says, for example, how to communicate about HIV and AIDS in a different language and tackling the stigmatization within a different language.
I'll take a step. So think about the first part of the question is really, it's about, you know, really speak, I think of like, as myself as an academic, speaking plain language, right? Speaking in terms that are, they're accessible to people, that people will understand. So it's really, part of it's like doing an assessment, understanding where people are, and then being able to like translate things in a way that people will understand, you know, sort of, you know, for just a lay audience, right? It's one of the things I really enjoy about when I give various talks is like I get to parlay things and, you know, it's just like in different ways. And being able to like, you know, meet people where they are to the best of my ability. The second part of the question is I always defer to experts, you know, to people who have expertise in the language capacity, but also in the field. Because, you know, just translating something is not effective. Understanding that like, you know, translation is very nuanced. You know, it's not just words, there's also lots of things that come into play. And someone who has that expertise and skill set to be able to do so is really important. And it can mean like, you know, partnering with someone to help, you know, if it's to help with the translation and their understanding of it so that way they can better communicate with the audience.
I think that's all the questions we have from our registrants, but if there are any, no one's like crooked their neck. If there are any questions, now as we round up with our current audience, or any like last, like closing words that our speakers have, we can open the floor to that.
I had a question. So just being in HIV and STI prevention just for 17 years and being an HIV TikToker, how powerful do you think social media has become? And how dangerous do you think social media has become due to within our field of expertise?
Social media, I think, is super impactful to education overall, especially TikTok. I'm always on TikTok. Fall down a rabbit hole so easily. To me, it's so educational. There is a level of danger when you do have folks who are not the right people to be speaking on certain topics, talking about them and spreading misinformation. It's best to find reputable sources on TikTok. I know that can be sometimes hard to know if somebody is reputable or not. But it's often like looking at how do I say this? What does the person like actually want to convey to you, and like what is their purpose of it? Like, do they have a certain agenda behind it, whether that's negative or positive, and being able to feel like I'm getting away from what exactly I'm trying to say. That's so tricky. But so sorry. I'll go back more to the beginning of your question. I do think that it's super helpful. There's so many different people to speak about HIV treatment and prevention on social media, and just sharing their personal experiences, I think is the richest part of it overall. People can talk about research all day, but oftentimes that personal experience is the most fruitful.
Just like that, I think social media can be really beneficial, and especially in terms of reaching, you know, populations or audiences that folks like me can't reach, or communicate things in ways that I can't communicate, right, or effectively or differently. I agree with you with sort of the challenges and sort of the inherent dangers, especially when it comes to misinformation, and how influential individuals can be. But by and large, I think of it as like a very powerful tool and mechanism that, I'm happy that many of our colleagues are just starting to utilize really, to engage with folks, to collect data, to disseminate information, and also to engage like, the virtual communities that are out there too.
One thing I love about what you're talking about with the personal story and people sharing their stories is that people watching it know they're not alone. And they hear that personal story and they might not know that person personally, but because they can go on to social media platforms and type in like a hashtag or like do a simple search, they can know they're not alone. I think that's a really important message for World AIDS Day too, is that you are not alone. If you have HIV, you're not alone. If you have HIV and cancer, there's people going through it and they can get through it. And I think that is one of the best parts about the social media that there is, which is the community aspect, to find those personal connections. And I think that people who are researchers have an obligation to return back findings that can be helpful to the community back to the community. I think it's an ethical imperative that that be done. That's my personal view, and that's also why I am on social media, although these are X is what is going on with X, but and Twitter, but I am on social media and I do try to get out and do events like this and other types of community work to get information out. Like, I feel like when you have information that's about a community that has implications for community health, you share it back. And that's like, I think a way that you can help engage and use social media for the good. Yeah.
Do you have any other questions?
Yeah, I have a couple of questions. The first one relates to, we're building off of the next 10 years question. And then the question is, do you see the HIV pandemic coming to an end in our lifetimes? Maybe not within the next 10 years, and that comes from hearing about how Australia has worked towards that or attained that. And then also about comes from science related news of the advent of CRISPR and how that has applications. Do you think that there would be a cure for HIV in our lifetimes, or more so just tapering and the pandemic?
I personally think that in about the next 10 years, I think that there will be a cure. They're working on it now, although it may be a little strenuous because the Capanouga shots are working. And that's something new that I'm experiencing. And I take it once a month, 2 shots once a month. And they seem to be getting better and better, my counts are better. And I think that it will be between now and the next 10 years, it'll do better. If it did that in these 10 years, you can think about the next 10 years where it's going to, if they keep working on it, you would think that, yes, it will start getting better. And that's what I'm looking for, because I want to be here in 10 years. And I'm hoping to hear more good news, not only just HIV, cancer too. And I'm hoping that, and I'm praying that in the next 10 years, yes, it'll be even better.
I mean, I would like to think that what my perfect scenario, I think in response to your question, is that if we start to address other social determinants of health, then we will move towards that. Because I think about, like, as Lauren talked about in the beginning and during their self-presentation, this there are other aspects that come into play. I think if we sort of from a holistic approach, if we're able to address social determinants of health, other conditions and circumstances, things that are policy related, things that are structural, right? Then we can have a more significant impact, because I'm always reminded of when things improve, it's the folks who are most impacted and burdened who usually are the last to benefit, right? But when those conditions are altered or changed, then we have opportunity to really capitalize and affect change in many different areas of existence and well-being.
Thank you. My second question relates to, is about, Lauren, about your work and your grant, working with, healthcare system at large. What are you hoping to learn from that, and what would like the next steps from those findings be? What does an ideal or good healthcare system look like, and
Yeah.
how would that really work, and benefit people?
So one of the things, I didn't talk about this as much detail, one of the things that my team is doing now is building what I would call like an intersectional data dashboard, so that you can, and like the data itself will let us see which populations are most impacted in terms of like who has care cascades that show the greatest need to address like holistically health system improvement to and improve like closing any equity gaps that we might see, like which populations have that. And then as we understand, like if it's at, okay, somebody's diagnosed and they have a staging, but they're not getting treatment. Like what does access to treatment look like at the intersections of race, ethnicity, sexual orientation, and social determinants of health? Like the intersectional dashboard that we would build would let us visualize that and then put that back to the health systems. Because one of the other important pieces of the grant is that we're partnering with it's not just research, we're partnering with the quality teams, like the leadership of quality improvement in the hospitals that we're working at. So that means you take that back to the hospital leadership and you say, I have data from your health system that shows this. And this is the equity gaps that we see in your specific health system. And I can do more than that. I can break it down by specific clinic and cancer type and like how that relates to what patients are having different outcomes and how does that look. So then you literally take it back to them and you're like, hey, you Chicago, hey, Northwestern, here's what I see for you. Here's what I see for you. So what are you going to do now that you see these differences to make them this, to actually advance better outcomes for people who are needing that the most? And you can tell them like, and you can do it at every stage. You're like, what we're seeing is that you're missing people because there's not equal access to screening. So then you say, okay, once we see diagnosis, we see there's a longer wait time for people to get their first appointment to address that diagnosis. And then you can say like, okay, here's your data. And the nice thing about these dashboards is that they'll update in real time. So then you come back and you're like, this is where you were last month. This is where you are this month. And then you literally have the exact information to tell them that. And like, you can go back to the clinics, to the providers, to the health system and say, do better. I mean, that's the idea anyway. But right now, this first stage is like, there's a lot of paperwork when you share data across health systems in general. So it's like navigating all the paperwork, navigating getting the fund, like the funding distribution set up, navigating the IRB, which we've done, data use agreements. And then once you get that infrastructure set up, then and you see what the data actually tell you, which is not, you have to get the data out of the health system and analyze it. Then that's when you can start to do the next project that really advances on the intervention for equity. And you also at that stage would be really bringing in the community partners because you have a tool to then show the community what those numbers look like. And with that, before that, you just are like, we know in general, there's not enough resources that are being dedicated to Black and brown people with cancer, LGBT people with cancer, Black and brown people who are LGBT with cancer, and HIV, et cetera. And you just know that in general. But then when you have the numbers that are specific and you can say, these are the patient IDs, and then you can go back to your health system and you can like find out who the patients are, because my data is all de-identified, but I can send it back and they know who the people are. And then they're like, here, do better. Like, and then you figure out with the community what to do next. I think that's the next step.
Are there some pretty popular, like boots on the ground, grassroots organizations that are advocating for people with HIV that you think we need to partner with? Because I'm outside all the time. Specifically, we're doing a lot in Bronzeville right now,
Awesome.
but I'm outside all the time trying to figure out what organizations we need to be partnering with to address, those low screening numbers and things like that. And I don't know the numbers, the data person had to leave, but who should we be reaching out to partner with? Because what I'm finding out, and I've only been a year in this position, but I was at Northwestern Medicine for 24 years before I made the pivot.
Yep.
And what I'm learning on this side is that the community organizations that are already out in the community, they're the ones that the people already trust. Because there's still gonna be that issue of distrust with medical professionals. So the more that we kind of partner with them, that's where I think we start make the biggest impact. But it's very tricky trying to form those relationships, partner with those organizations, find the organizations. And then that's where they get a lot of their funding from, you know, when we're partnering with them.
There's at least 51 organizations in Chicago that address HIV prevention, care, and treatment. And the reason I know that is that's how many AIDS services agencies are funded from the city, like from CDPH. And EDIT, which is another program here in ISGEM, Evaluation Data Integration and Technical Assistance Program, is the evaluator for all 51 of those. And so they have that list that can be easily shared. But it's
Yeah.
groups all over the city.
Yeah.
I feel like I was on social media this morning. I saw Project Vita has got like an event going on, like a walk, and they're on the west side. There's like south side groups doing work. Like there's, you know, like 51 groups. And so we could get a list over, and there's more than that. I'd look at the people in this room. Like we already heard, it's like people are like, I do prevention work. Look at this, you know, look at, you know, talk to people and get out there. But yeah, there's a lot doing work that right now we could talk to.
Send you a quick little email.
Awesome.
Share that list with me.
I'd be like, raise your hand right now if you're one of those people, like in the room.
Well, I mean, I'm not one of those people on the south side. I work at Haymarket in the West Loop, but
Okay,
I used to work with the Village in University of Chicago in Hyde
Yeah.
Park. That's through the Chicago HIV Elimination Center. That is, and then of course there's Howard Brown in Hyde Park. There's also Chicago Women's AIDS Project in South Shore,
Yep.
off of 71st and 71st and Jeffrey. It's maybe about like a little further west of Jeffrey, maybe about 4 or 5 blocks west. of
We can
Jeffrey.
change the information,
Yeah.
because a lot of those that you mentioned, I've actually reached out to them. However, when you don't really know the in-person.
Yeah.
Sometimes it's hard to get a response.
yes, yes, yes.
Okay, y'all heard me say I've only been in this position for a year, right?
Yeah.
So I'm working on it, but if you have an in-person that I can have a direct streamline, I'm already working on 2024 calendar, so I need it.
Yeah, absolutely. We'll exchange contact.
Yeah.
But somehow communities don't get that information.
Yep, which is why I try to share it a lot.
Yeah.
Are you still at Apostolic?
No,
No, okay.
and not because I love Apostolic. I left because of my health.
Oh, I understand. I used to go to Apostolic.
Yeah, I left because of my health. But, we don't get that. I live in Woodlawn,
Okay.
and we barely hear anything about it. It's lost right there. We're lost right there, so people don't know who to reach out to and where to go for these things, you know. And leave in the hospital, they release you and you never get anything else
Yes.
from it. You know, because with my cancer the first time, they gave me a little party at the hospital, you know, you over your cancer, and I never heard from them since.
Yeah.
To come in and get some treatments or anything. So, I know my body, and I know when something's not working right. So I call and tell them, this ain't right for me, cause this is unusual. That's the only way I can get an answer. But we're looking out for them to call you and say, come in, you never hear from them again. And that's the hardest part of it, you know, cause you really want to know, but you never will hear anything else after you leave the hospital. And it's an ongoing thing because my last cancer was over 20 years ago. And not too long ago, I came back with the same cancer. You know, and I was scared the last time because the treatments were different. Like I said, I was taking chemo for 21 hours a day for 5 days. And 6 weeks. And I didn't understand it. The first time I just got a treatment, went home. You know, but this time I had to stay in the hospital. I had to stay in the hospital for 3 weeks. And so, I really didn't know what was gonna happen. But I did say that I was gonna try and see what happens, you know. But I don't know what's gonna happen after it's finished, you know, because it's not over with, because they say it's over with. You know, and there's no longer can come and go. It's something that can come and go. And I would like to know, and like at least get tested, make sure that they came back and don't have to wait till you come back on you. So I'll go over and find out you got cancer again, because I'm hoping, praying that it's never come back again. It's not a fun thing, because your body goes through so many changes. You know, one day you feel like this, and you know your body, then it changes. And each and every day your body changes. And you have to fight all of these things off, you know, and they don't explain that to people.
I definitely agree, we could have a better survivorship clinic or something,
Some place that you can go
yeah.
to, other than going to the hospital and waiting in the hospital, because I waited in the hospital 17 hours and never seen a doctor.
I remember that, like,
I had another question, and again, just relating to social media. So with social media and how powerful it can be with regards to that, common connection. How do you think social media can be used to refer people to boots on the ground referral services with regards to, HIV and STI services? Because I personally have actually been on the phone with a TikTok follower, as well as a person, as well as an organization in Raleigh, North Carolina. And she was like, I'm on my way. I was like, do you need me to stay on the phone with you until you get there or while you're there? And she's like, no, but I'll let you know how it goes. So like, how do you, being that, just that one connection, I mean, that's of like 100 different connections I've made on social media. But just being that one connection being so powerful in and of itself, how do you think that social media can branch out? How we as prevention workers can use social media to branch out for those referral services, to take advantage of social media?
I definitely think it would be useful to just promote services as best you can. Amplify the voices of the different organizations. If there's organizations that can have their own social media, that's great. I know that's not always possible for folks to be able to do. As well as, I mean, maybe even bringing different people from the organizations onto your platform
Yeah,
and allowing them to push their information, push the different programs that they have available. And then just sharing with as many folks and just try to get kind of like a share tree going. You share with 5 people, then you get that one person to share with another 5 people. Being able to spread the information is probably the biggest thing. Knowing what hashtags to use, what sounds that are the most popular to use to be able to get people like recognizing or seeing this particular post. They may not have seen it before if you didn't put any music or any sound behind it, but a lot of times people are just looking at those different popular sounds, and then they'll see whatever programs that are being promoted, or trying to figure out ways to weave in promotion of programs into different social media aspects. It's important as well, whether that's just TikTok, Facebook, Instagram, talking about it as much as you can.
Cause you're kind of like a community health worker.
Mhm.
And a lot of those organizations are actually looking for ambassadors. So like one of the organizations that I'm partnered with for colorectal cancer, the Blue Hat Foundation, she has an online training course where you can become an ambassador. And then you can come with her to some of her events to help raise awareness about colorectal cancer and prevention and things like that. So a lot of the organizations that you support and believe in, you know, in their mission and vision and whatnot, I would reach out to them to see if they're looking for community health workers or ambassadors. And then use that on your platform too.
Well, trust me, I already secured a
Yeah.
contract with Q Care Plus.
Yeah,
Nice.
yeah.
But I just recently ended it, so, but that was the extent of my question, thank you.
I would say along that line about agreements, I've made social media partnership forms, like where you're talking about the tree of sharing. Like I've actually written like agreements amongst a series of community partners where you like write out the steps of like how and when you share with each other and you develop like the resources and set up a program that defines that more detail. And it also, like you have social media guides for your really important campaigns that you develop, literally, like you develop and register your hashtags that you would define, you're talking about sounds and stuff like that. You actually write down what those are. You have sample text that you generate for posts and you share that guide and resources. You probably already do this, but like that, and then you partner that with your partnership agreement and share that. And then if you want to monetize it, I'd be talking to the various places looking for ambassadors, which you already have the contract secured, but like I've done stuff like that. Like,
That was just one
yeah,
contract.
no, but I mean like.
And I was lucky to get that.
Well, there's more.
Yeah.
Giving you the blueprint.
Yeah, that's really what I've done things like that in the past, like from like being a community organizer myself too. Trying to do like the finding the share tree, what it is. Yeah.
Yeah, I think that for the sake of time, that has to be our last question slash comment. Thank you everyone again for not only interacting with our panelists, but interacting with each other. I can see this is definitely a room of connections. But I want to say a big thank you to our panelists, our patient speaker, our moderators, and you guys as well for coming. And our online folks that are everyone's kind of trickling in and out. But I'm very grateful that everyone was able to come, and hopefully you learned something new and found someone or some people to connect with in the future. I think my last little announcement is, as mentioned earlier, if you did need a parking pass, find me, I'll probably be here. So you can sign us off and you can get your ticket validated. Other than that, thank you guys so much for coming today, and that concludes our panel.
See you as always.
First of all, I love the red. Very appropriate.
Yeah.
Do you mind if we get a picture with you guys like right out on this wall?
No, no
Yeah.
problem.
And you too.
Like stand up, I can't stand up. Oh my God.
Right.